Welcome to On Becoming a Healer. A brief note before we start. This episode discusses suicide and mental health crises. We know these topics can be personal and sometimes painful, especially for clinicians who have cared for patients or colleagues affected by suicide. Please listen in whatever way feels safe for you and step away if you need to. If you're having thoughts about harming yourself, support is available right now. In the United States, you can call or text 988 to speak with someone confidentially. If you're elsewhere, please reach out to a local crisis line or emergency services. Reaching out is a sign of strength, not weakness. Okay, so now let's get started. As a primary care physician, the possibility of a patient dying by suicide scares me in a way that other serious illnesses and conditions don't. I know that my patients who have cancer or heart failure or other conditions that can be lethal may follow a bad course. But I have learned about the pathophysiology of that, and I feel a certain sense of control and understanding based on the training I've had. But with suicide, it feels different. I think that the amount that is known about suicide and how to prevent it is far greater than what most physicians are aware of, and there is hence a big gap. So I realize we have an opportunity to talk about this with Stefan. Stefan has been conducting a major national study looking at suicide in patients who are on chronic opioids for pain, who are tapered by their physicians, often without their consent. While Stefan has been doing this study, he's been working with some of the leading suicidologists in the world. So there's a lot to tap into there. Hi, Stefan. How are you doing?
Hi, Saul. I'm doing okay.
Good. Okay. We know that 45% of patients who die by suicide have seen their primary care doctor in the past month. We know that primary care doctors ask about suicide in only about 50% of primary care appointments when a patient has an existing diagnosis of depression. And when we do document it, it's got a sort of perfunctory, efficient task completer mindset, at least as I see it. With my residents, I'm guilty of this. I'll often say, hey, have you asked about SASI, meaning suicide attempt and suicidal ideation? And they'll say, yeah, I've done that. I'll be like, okay, be sure to document it. And that gives me a little bit of a sense of, okay, well, I've covered my ass. If something bad happens here, hey, we asked about it, we documented. And also specifically, they refer to the patient, quote, denying a suicidal ideation. And there's a certain irony in the term denying, because we know that if a person is denying something, it implies that it may actually be something they're not telling us. And that is, in fact, a major concern. Patient being less likely to tell us that they're in trouble because they're afraid of losing their autonomy, and they may actually be quite at risk. So I'll also say that this has been a scary issue for me at a personal level. When I was thinking about it this morning, I realized that at every stage in my life, there have been people who have died by suicide, either people I knew directly or they were the loved ones of people I knew very well. I was thinking back to residency. It was my PGY3 year. One of the residents I trained with died by suicide just a month before we were graduating. And a former medical student of mine calling me in 2020, just shortly after the pandemic had started, to say that his teenage son had jumped off a bridge. At my high school reunion, a close friend shared with me that his father, who I remember well, had shot himself in the chest. I could go on and on. This is haunting. It's scary. And in the United States, the rates of suicide just continue to go up inexorably since about 1999, even as they fall in European countries for the most part. Lastly, I'll say that when I was looking at a very widely listened to podcast that's designed for physicians that covers pretty much every topic under the sun from a clinical standpoint, there's really no discussion of preventing suicide other than within our peers. How could there be such an omission? I mean, there's all kinds of weird, obscure topics that are covered that are far less at the center of primary care. I don't know if I have an answer to that, but I think it has something to do with this mindset that this is just something that we have to screen for in a perfunctory way, and that maybe we haven't in some way classified fully as a disease. We know what cancer is, we know what heart disease is, and yet suicide doesn't seem to fall in our mind into that kind of package with a label. So, Stefan, let's start by having you tell us a little bit about the study that you're doing.
Yeah. And so I'm a general internist. I do primary care. I've long been interested in pain and addiction. And I took an interest in the situation that emerged where doctors began reducing opioid prescriptions pretty aggressively. And I began to hear about and even in one instance witnessed the emergence of suicidal behavior in someone who was being reduced involuntarily. And I think at the start, I had a pretty simple understanding that it seems like reducing opioids sometimes makes people suicidal. And there's statistical data that correlates those two events. But you can't really understand what's going on without getting the story of the human being. So it's like, let's get the stories of the actual tragedies, the way airplane crash site investigators investigate airplanes that have gone down to the ground. Let's understand all the things that came together. And I began to learn that the story of how somebody comes to take their own life is going to require structured and careful inquiry across a wide range of topics, above and beyond what happened to their medications, from how the person grew up, what were the things that happened earlier in their life, how connected were they to their friends and their family, and did that change in recent years? What was their level of ability and could they get around? Did they have a social life or not? What were the medical problems? Did they ever talk about feeling that they were disconnected from others? And then what were the events and the lead up to dying? And the only way to acquire these stories is to ask people who've lost someone to suicide if they are willing to talk to us. And there are great uncertainties about the kind of story you get when you speak with a proxy, but at the same time, there isn't some other panopticon that can sort of allow you to look at everything that happened to an individual who is now gone from us. And that method has been referred to as psychological autopsy. And when we do it, we select people through a survey, and then we set up time and pay them to do an interview. And people who wish to be interviewed are interviewed and often find it therapeutic, actually, to describe what happened. So that's the study, and it's called CSI Opioids, Context of Suicidal Ideation and Action Surrounding Opioid Transitions. That's basically what the acronym stands for. And anybody could check it up on csiopioids.org.
So, yeah, thank you. I'm going to ask you to draw on one of the dozens of cases where you've done this
Yes.
type of autopsy in a moment. But before we do that, one thing I've learned from you is that there are some really strong theoretical foundations for understanding suicide. And I want to hone in on two of them because I just found them particularly intriguing, and I think they're highly influential. And by the way, these are why we call these theories. They're also deeply grounded empirically in incredible
Yes.
amounts of research. So I want to start by just asking you to initially tell us about the work of Thomas Joyner, who I know you've been working with closely.
Yes. So around the late 1990s, early 2000s, Dr. Thomas Joyner and colleagues, including Van Orden, devised something they referred to as the interpersonal theory of suicide. And it's really important to acknowledge that theories of suicide have been with us since, at the latest, the 19th century, when Emil Durkheim, a famous sociologist, came up with a theory of suicide at the time, which included relationships to others as part of that theory. And picking up on that strain, Joyner and team proposed that two key relationship factors that influence suicide are the perception that one is a burden to others and the sense that one doesn't belong to a community or group, which they refer to as perceived burdensomeness and thwarted belongingness. In the theory of perceived burdensomeness, the person who's taking their own life is thinking, it'll be better for the other people around if I'm not here. It's a mistake, but it's a kind of generosity that's just misdirected from his point of view. And then thwarted belongingness is the sense that I don't belong and I'm not connected. The two elements together have some empirical support over the literature that has been developed in the subsequent 20 years. And then there's a crucial third element, which Dr. Joyner pointed out early, which is that you have to have the acquired capacity to take harmful action against yourself, which is to say, you have to overcome the basic reality that most of us are afraid to hurt ourselves. And this is something that isn't fully explained, but it may involve potentially having suffered a great deal or experienced great trauma before, and the belief that you can sort of do it. It requires considerable focus and attention. And I heard Dr. Joyner say that's a misfire. There's a certain bravery in being able to harm yourself, and yet there is a terrible mistake being made at that very same moment. But that capacity has to be there, or else you won't act.
Yeah, I think a helpful way of summarizing Joyner's theory is I am alone, I am unwanted, and I am unafraid to die. And the last piece is so critical because, as Joyner's pointed out, there are many people who want to die, but they are not capable of killing themselves. And there's what I think is probably an evolutionary will to live, which I think has been extensively written about. It is known, and Joyner has written about this, that among other species, even down to ants, there are other species where suicide is common, often to save the tribe. So I think if an ant is infected with like a parasite that could spread, they will leave the ant hill and die. But of course, the misfire is in the example of a human suicide, where the person perceives that they are a burden to others. And perception is really the critical concept here. The second theory is actually one I'd like to pick up on.
Yeah.
And these theories do not contradict each other. As I see it, they complement each other. But I want to talk briefly about the work of Igor Galinker, who has, among other things, described what he calls the suicide crisis syndrome, which he has been working to get into the DSM as essentially a new diagnosis. At the heart of the account of the suicide crisis syndrome is a feeling of entrapment and frantic hopelessness, a desperate desire to escape an unbearable life situation. I just want to emphasize how important I think that is, which is that when you're with a patient and you're concerned about the possibility of suicide, rather than just saying, have you thought about killing yourself? Do you have a plan? He, building on his theory, suggests we ask, are there any solutions to the situation that you are suffering from? Do you feel trapped? Do you feel pain talking about this situation? Those sorts of questions are so specific and relevant to theory than just the rote questions I learned about asking someone about SISA. And he also says that there have to be other elements as well as the entrapment feeling. One of them is that there has to be a state of emotional pain, which typically there is if someone's feeling trapped. But there also has to be a loss of control over their thoughts. In other words, they're ruminating about this. They're thinking about it constantly. He'll ask if it's at the point where they can't sleep, that it's causing insomnia. In other words, there's really no relief from these uncontrolled thoughts. And then finally, he's interested in whether they're starting to withdraw socially from others. So as I hear this theoretical framework, I start to have ideas as a primary care physician about where I can go when trying to elicit and assess a patient's situation beyond what I've been doing to date.
I think that you can imagine conversations with people who are describing distress in which you ask, do you feel like you're trapped or like you have no choices at this point?
Yeah, you're trying to look at is, does this person feel like they are trapped in an unbearable situation? It really boils down to that. Now, I'd like you to pick a case, and I know there have been quite a few of them, but where you and your colleagues, your team have done a deep dive talking to the survivors of somebody who died by suicide. And again, in your study, there's a specific focus, which is that these are people for whom there was a chronic illness, opioids were tapered. Really, and I think this is so critical, you guys are looking at this the way you should, which is big picture, using some of these theoretical frameworks.
The way we do our recruitment, we are asking the public at large, are you the friend or family of somebody who you lost who had chronic pain and whose opioids were reduced? But the questions that we ask in an interview begin very broadly. They unfold over about 2 hours with trained interviewers. One of the stories, I'm going to change some of the information to make sure we don't inadvertently reveal identifying information. We were looking at the death of a woman in her early 60s. She had been someone who served in the military, who had experienced military sexual trauma, which means that there was something, potentially a rape, but maybe less than that in some way in military service, had post-traumatic stress disorder, and also around the time that they left the military had a severe injury with severe chronic pain. And as part of their care, they were in some mental health care for a while, and they were also on opioids. Those opioids were at a fairly high dose. The medication was oxycodone. The doses were in the range of 100 to 120 milligrams a day, which is to say high doses. And yet she was not functioning great. She wasn't doing well. And a relative who was actually regarded this individual as a big sister figure, even though it wasn't her sister, began to get worried about her and said, why don't you move down and live with me? You don't seem to be doing well. And brought her down to her home, which was in a different state in the south of the United States. And they kind of coped together. They lived in the same apartment. They went, out to restaurants periodically. There were some social activities. There was a little bit of biking. There were some things they did together that sounded okay, but she wasn't great. And then she wound up shifting her medical care to a university-affiliated clinic. And as far as the patient understood, the word out of the doctors in the clinic was, you're going to have to come off the oxycodone. And I'm just going to word that again. You're going to have to come off the oxycodone. That's what she heard. Now, Could it be that the doctor said something very sophisticated and subtle and experienced, had an elaborate conversation with her? Maybe. But in my experience, having watched many of these cases over time, I've learned that a lot of doctors in the last 5 years have basically been pretty blunt. Like, you're going to have to come off of this. I can't prescribe this. We can't prescribe this. It's no longer considered good to prescribe this, blah, blah, blah. That's kind of where they are. So they took her off the high doses and shifted her to a dose roughly 1/10 or 1/8 of what she was on. I don't think they did it all at once, but they did it relatively quickly. And then nothing happened instantly. And this is one of the interesting stories in our study, is that routinely we hear this. There is, for some people, a crisis at the time of a sudden reduction in medication. But for a lot of people, what we've observed is a long-term kind of failing of the patient. In this case, the person who spoke to us said she just dwindled away. She became more and more withdrawn from going out. She became unable to go out to do things. She was no longer interested in going out to do things. There was no real mental health care plan here at all. She just accepted the decision of her doctors and became progressively more isolated. And then one day, our informant came home and found that the older sister figure had cut herself, we think, the wrists, and then exsanguinated and passed away. And that was all she could learn of the story. And the person we spoke with actually attributed blame in a way to a variety of parties, including the patient. And our informant also said that they believe the doctors really caused a big problem when they said, you're going to have to come off the oxycodone. And this sort of withering away or dwindling away, which is the expression our informant used, is one that we've heard in multiple cases. We don't know what her mindset was at the very end, but you could envision the possibility that it might match up to some of the things we just discussed.
Yeah, this story highlights that physicians can actually make things worse. So it's not just a question of our learning how to be better at detecting a patient at risk for suicide, but we also have to stop being terrible in some cases in a way that actually worsens the situation. Reminds me of a groundbreaking book written by the author William Styron that came out in the late 1980s called Darkness Visible, a memoir of madness, in which he described his own experience with profound depression that came on relatively late in life and
Age 60.
resulted in a high risk of suicide.
So this book is pretty short, and I do encourage people to consider reading it, or in my case, I listened to it, and he's the reader, called Darkness Visible. In the book, he describes kind of progressively worse and worse depression. And it's only near the end that he begins to think of taking his own life. And he is getting ready to think about acting. But one evening, he's watching TV. And in the middle of watching the movie, he hears a strain of music from Brahms, and specifically a strain of music that he remembered his mother used to sing when he was a kid. And he suddenly has this moment where he realizes that there are certain things about life he has loved and that he might still love again. And at that point, instead of proceeding to figure out the next step to kill himself, he begins to talk with his wife about the fact that they need to get him to the hospital. And that is what launches him onward to the hospital.
Yeah, and it was striking that his physician had discouraged hospitalization because of, quote, the stigma.
Yeah.
Which was obviously incredibly bad advice and really shocked Styron that even a psychiatrist, again, this is in the late 80s, was raising the question of stigma when, in fact, this person's life was at extraordinary risk. And he gives other examples of his doctors being more of a hindrance than a benefit. Once he's in the hospital, he describes in group therapy a, quote, odiously smug young shrink who supervised group therapy. He was extremely condescending and bullying and reduced some of the women to a state that he seemed pleased about, unquote. And he goes on to say that the non-physician staff, the rest of the staff, he says, were exemplary, except art therapy, which he described as organized infantilism.
Organized infantilism was such that, and I think this is in a weird way a good sign for him, but he said in art therapy they were asked to draw, a place that was important to him. So he's going to draw home, and he sets out and draws a house in the manner of a first grader, which is to say a box with a triangle on top, and then 4 little boxes in it with crosshatches on each one to signify windows, and then a little rectangle door. And that's it. That's the place that he draws. He does this in anger. He is trying to troll the art therapist. I also think it's a very hopeful sign. If you're pissed off enough to sort of do something that sasses back at the staff, it's the beginning of finding some sort of place for yourself.
And, he contrasts this with how helpful non-quote experts were. He describes how when he was in the hospital, a friend of his who was recovering from severe bipolar depression, would call him every day to
Yeah.
coach him and support him. And he describes him as critical to his recovery. And he needed to be told over and over again that this would pass. And this gets back, I think, to the theory we talked about, which is letting him know that you are not trapped, that there is a way out. And he also describes his wife as being incredibly important to him as well.
It also gets back to the idea of thwarted belongingness. If people are saying, hey, you belong to me, you belong to us, it's harder to feel that you don't belong. You still could, but it's harder. If people seem to want to interact with you, you still could argue to yourself that you are a burden to them. But there's a little bit of counter evidence there in the sense that people are saying, well, no, this will pass. I'm with you. I want to hear what's going on. How are you doing? I mean, there is connection there. Admittedly, as doctors, we aren't necessarily people's friends, but we can also provide some of that, I think.
Yeah, and I think this is a really important point. I'm reminded of a story that the physician and author Rachel Naomi Remen tells of when she was in her 20s. And she was diagnosed with Crohn's disease. This was a long time ago. It was in the 1960s. And she was hospitalized at the same place where she was also working. And she had to have an ostomy put in. At the time, surgery for Crohn's disease was really a big deal. And she had this ostomy put in, and she was recovering in the hospital for weeks. And she could not imagine herself having a life with basically a bag. She was a single woman. And she started hoarding the tranquilizers that they'd been giving her with a plan that she would take all of them at once after she was discharged. She didn't want to, as she
Oh,
put it, kind
God.
of humiliate or embarrass her team by killing herself while she was there. And
Wow.
and what changed everything was that one day a young ostomy nurse came in and behaved in a way that was completely different from everybody else. All the other ostomy nurses would come in. And, they were courteous. They would come in, they'd wash their hands, they would gown and glove, and they would come over and they would gingerly replace her ostomy bag. And then one day this young nurse comes in and she's very careful. She washes her hands, but she doesn't put on gloves. Gloves are not necessary in this situation. And she just comes over and she casually starts changing the bag. And during this time, she was just chatting with Rachel in for lack of a better term, girl to girl way. She was talking about, it was apparently, I think it was a Saturday evening, and she was dressed up. She was planning on going out with friends. Apparently, Rachel had also gotten some nice clothing that she was putting on, but she was going to be stuck there. And this nurse started talking about fun things they were going to do and her nails. And Rachel realized that this nurse wasn't seeing her as a patient. She was just seeing her as just another young woman and just having a good time and chatting. And
Hmm.
Rachel suddenly realized that she could see a life for herself. She could have that life, and that this practical problem she had didn't need to prevent her from that. And she decided not to kill herself. And she said, to this day, she's forever grateful to this nurse who was just engaging, just being herself.
Wow. I love this.
Rachel, who I probably should call Remen, but I feel like calling her Rachel here because this is sort of the story of a young woman who didn't die by suicide. So to me, that's just an incredible example of a provider who just was a human being. That's so often what we don't do.
I love that story. I think that we often get a little bit locked into our role. And here, she's not violating a rule of healthcare by speaking to a young woman as another young woman. She's just being a peer as well as the person who's helping with her ostomy. And it's perfectly fine to do that.
I know there's been research on whether the way in which the physician or healthcare professional interacts with the patient who's suicidal or potentially suicidal can affect outcomes. Could you share some of what you've learned looking at this research?
Yeah. And I think it's important to acknowledge that there are maybe hundreds of researchers who are publishing in peer reviewed journals, and we're not going to do justice to work done by lots and lots of experts. But a few things stand out to me. One is lethal means reduction. So if somebody has a gun, it is reasonable to surmise that maybe removing the gun could help. There are lots of observational studies that suggest that if the gun goes away, there's a person's a lot less likely to kill themselves with the gun.
Yeah, Stefan, I have got to break in here just to share a story here that this reminds me of. As you know, from time to time, I've talked about my godfather, Simon Oster, the family physician and psychiatrist who was so influential in my life and who died in 2020. I remember him telling me once about a patient he knew pretty well, and he determined during a visit that this person was suicidal and had a gun. And it also became clear to him that he couldn't be sure that this gun was going to be safely removed. And so he did something kind of impulsive and, I don't know, in my mind, kind of incredible, but not that surprising for Simon, which is he was like, all right, let's go get it. And he just went with the patient home, just said, we're going to your place. And he just went and got the gun, just took it from him. And he threw it in his trunk. And, sort of classic for Simon, he forgot that he had this gun in his trunk that he was driving around with. And his wife opened the trunk and was like, what the heck? And so Simon, told Rosalie about, why he had this gun in his trunk. And Rosalie was like, "Are you kidding me? Like, that's not even legal. You don't have a
It's
license
not,
to
it's
carry the gun,
right.
let
It's
alone
not
someone
his
else's
gun.
gun." Yeah. And Simon sort of shrugged and was like, "Yeah, I know that I have a law." Simon actually also had a law degree. I should mention that. He was just very focused. And believe me, don't try this at home. I'm not recommending that if our patients have a gun at home, that we should jump in the car and go get it. But to me, it reflects Simon's unself-conscious engagement. He didn't think of his patients, at arm's length. If there was a problem, he just wanted to solve it right away. So I love that intuition. I love that way of thinking about it. So sorry to interrupt, but I just wanted to share that. So go on.
Saul, you and I often talk about the role of caring relationships, and we're suggesting that if you speak to someone and try to engage them as a real human being who you care about, can that help? There has been a kind of an intervention developed called caring contacts, and the original experiment with this was carried out at University of California, San Francisco, where people who had been psychiatrically hospitalized with suicidal crises or something close to that, there's a subset who simply declined to engage in any follow-up care. And this is done in the late 1960s, early 1970s, which is to say, I do not think there was a standardized informed consent for the intervention, but the intervention consisted of the clinicians who took care of the patient in the hospital writing little short notes, handwritten, 2 to 3 lines, pretty generic notes. I think they were along the lines of, "Hello, I hope this note finds you doing well. It's been a while since we've seen you. Let us know if there's anything you'd like to talk about." And these handwritten notes would go out to a randomly selected half of the people who did not engage in care. And that was the full intervention, was a note. And there actually was a difference in the suicide death rate in the people who received these little caring contact notes. The people who received the notes had a rate of 1.7%. The people who did not receive the notes had a rate of 3.6%, suggesting that these notes, which are highly generic, were helpful. Since then, there have been other studies attempting to use the same kind of modality, usually on smaller samples, and they were text messages, studies, what it looked like they were now contemporary. So some of the studies are contemporary. That means there's both informed consent and there's regular follow-up care. So there's somewhat less extreme situations, and they haven't found an effect on suicide, death, or attempt. But again, it's quite difficult to study. If somebody agrees to follow-up care, then you're testing whether adding a text message of a generic nature changes their outcome.
I mean, I think that what's fascinating is that it appears to have saved lives, and yet in some ways it's so lame, right? I mean, the idea that you're essentially pretending that you care about somebody, to be quite honest, you're randomizing people to have the perception of being cared about. They're getting these generic letters that are being sent to them because they're in a study. And I think this was done at a time when you didn't actually have to tell patients that, "Oh, we're going to pretend we care about you and send you these notes." But it actually moved the needle. And when I saw the studies, they include some of the examples, and they're nice little notes. They're handwritten, but they're very generic. Like that note, the note that's sent to patient A could also have been sent to patient B. It doesn't get into anything specific. Now, I think it does highlight the fact that, first of all, healthcare professionals have a special power. I think
Yeah.
that our patients really do take it seriously. It means a lot to them when we reach out to them. And I think also in this particular studies, I think you mentioned, the note was signed by the person who had done like a 3-hour intake with them. So they knew that they're getting the note from somebody who'd gotten to know them well. And now this person was reaching out to them. And so even though it's fairly generic, it just shows the power. Now imagine what it's like if it was really caring, like if the physician, is genuinely engaged. It's hard to study, but I guess want to say that what little data is out there suggests that we matter. And if you start to put this in the context of frameworks we've talked about, where you're working with them to help them feel less trapped, to feel more connected, and then to connect them with others, there's power there in combining your cachet as a physician or healthcare professional with actual knowledge about where you might be able to intervene through your relationship with them.
I think one of the things I really struggle with this topic area and with this discussion about caring is that suicide is an extreme state. This is such an extreme situation
Yeah.
that it merits being called different from other forms of human suffering.
And when Galinker talks about the suicide crisis syndrome, he's talking about that acute, frantic state which is extremely high risk, where a person is on the brink of death by suicide. And he says that at that point, and again, he acknowledges he doesn't have the research to prove this yet, and he's trying to do the clinical trials, you need medication. You need an intervention that is pharmacologic. And
Yes.
there are really three categories of drugs that need to be on the front line. The first is a benzodiazepine to control this frantic state, this overwhelming anxiety.
This could be like Valium or Ativan or something?
Yeah, exactly, exactly. The second is you need an antipsychotic that is going to help control the out of control unwanted thoughts, the racing thoughts that are overwhelming the person and that are so dangerous. And the third, and this is he acknowledges the most controversial, is if they're actually in extreme pain, which they often are, opioids. And he says he's talking just like for 48 hours, just to dampen the acute crisis. So I just think it's important to understand that there's a continuum here, and he's saying this is the deadly state that we need to acknowledge patients escalate into. There's a video by Dr. Joyner of a patient or an individual about 15 minutes before they subsequently died by suicide, not blinking. When you watch the entire video, there's no blinking.
And to be clear, it's not what he recorded knowing they were going to die.
No, nobody knew this, but he says that's a characteristic, and it shows this person is in an intense hyperarousal state. He talks about the fact that that patients who drink heavily often stop drinking before they die by suicide because they need to be in a highly aroused state in order to take their own life. And so I think it's important to understand that if we're kind of rank ordering the urgency of situations, that it's a suicide crisis syndrome that we need to be on the lookout for above all else, but that there are many stages before that where we will more often see patients.
And where we have a chance to connect and help prevent that crisis from developing what we think.
Exactly.
Or by acting like a human being, reduce the tendency for people to draw the most extreme conclusions.
That's exactly right.
Yeah. I think there's moments where people can intervene to take what's an incipient crisis and reduce the chance that it's going to get much worse. And when I think about this, I wind up drawing on examples from childhood and adolescence where I felt absolutely trapped and devastated by the sense that nothing was going right. And this is not precisely the same as a suicide crisis occurring in an adult. And yet there's enough instances where I was rescued by the care of others that I think it's just worth sharing.
Please do.
Yeah. So, one example of many that comes up for me is somewhere around ninth grade. And this was a age where I had, I guess I say some trauma in my upbringing and had settled in on the idea that I would just be a great student and that would rescue my very fragile ego. But I didn't feel right in myself in eighth grade as I got ready to go to high school, just because life had been tough at certain points in time earlier. And I got convinced that I looked wrong, that I didn't look right. Everything was wrong with my body, myself. So all I would say is that it reached a little crisis with me. And I was eventually in a dark, closed room, in my own bedroom, crying and just feeling like there was no future. My mother came in and she heard something in how I spoke. I think I said something like, I just wish there was a pill I could take that would make me look good. And she changed on a dime from sort of chiding me to, okay, tomorrow morning this is very bourgeois, we're going to Saks Fifth Avenue. And basically she took me to this incredibly fancy store that I had never walked in before. I demanded to be left alone for a period of time and worked with a salesman there. And I think we found one pair of pants and two shirts and one pair of, this will date me, but one pair of Sperry topsiders. And, there was a long discussion with the salesman and my mother about why these things would work. And I wore the hell out of those clothes for the next year, to the point that there were holes in the sleeves and everything. And I think what happened for me is not so much that the clothes rescued me, but that my mother rescued me. And she said to me around that time, she said, clothes are your armor and we need to get you an appropriate set of armor. And it was such a validating moment for such a fragile person as I was at that moment in time. And I could think of many other times in even bigger crises in which I felt trapped or I felt there was no chance that I could make it through. And even though this one's precious and adolescent, it's a hint of the value of somebody saying, I see where you are. Let's help you.
I love that story. Obviously, your angst about your looks it's just scratching the surface of a hard set of
issues
that are hard to characterize. And yet your mom approached it just intuitively with this in quote unquote superficial approach. Okay, let's go get you some clothing so you look better. But it was a loving response. It also was, it involved an activity, going together to do something. It involved decision making, which gave you an opportunity to have some control, to be discerning, and it worked. At least it worked for that moment.
Yeah.
And so I just think, I think that's it's a great example of how our response to people just has to be fundamentally human. And because people, and again, this goes back to Joyner's theory, people feel disconnected, and this type of engagement brings them back in the same way that we saw with Naomi Remen, by the way. The Ask Suicide screening questions, ASQ, in one study recently showed that about 9% of the time adolescents will screen positive.
Oh, wow.
So at any given time, young people thinking about suicide is common. Now, again, as we know, there's a huge distance between thinking about suicide and attempting to die by suicide. But it shows the degree to which this is an issue in that population, where
Yeah.
it's become, I think, the number 2 cause of death after accidental accidents. I think up through somewhere in the mid-20s. And suicide is now being seen as early as age 10. The age at which people die by suicide has been going down as well as we see this increase in death by suicide.
I think it might be reasonable to just try to highlight that in telling the stories about where a caring intervention from a friend or family member protected us, we can't suggest that every doctor or every nurse is in a position to do the same thing, but just that there are moments in the professional life where we can be present as a fellow human being that might make a difference. It's hard to prove through randomized controlled trials because you can't randomize people to care. But there are moments where we can show caring even if we're not going to take the patient shopping at Saks Fifth Avenue.
So I think the take-home points for me, as a primary care physician, are the following. So first, I want to do a better job of picking up on this with patients. So I want to be asking patients, anyone who's depressed, if they are suffering in some way, I'm going to be asking them if they're feeling trapped in this situation. If they do imply that they're feeling trapped, I'm going to try to assess, is it controlling your thoughts? Is it affecting your sleep? Have you told anyone about this? Once they start to appear positive, these things start to look like a serious issue. I'm then going to try to figure out, is this somebody who is approaching a suicide crisis? Because that, of course, is going to change my general approach to it. But if they're much earlier in the process, and I'm getting more the sense that there's somebody who is kind of fits the Joiner model of feeling disconnected, feeling like a burden, then I'm going to be thinking more in terms of, first of all, do they have an untreated mental health condition like depression? If so, of course, that needs to be treated. But then what can be my role as a healthcare provider, in this case as their doctor, in helping them feel more connected, in helping them think about how to get there? And then coming back to your study, when you were describing the case about the physician saying to the patient, we're going to have to come off the oxycodone. The doctor is so focused on treating themselves as opposed to the
Yes.
patient. Like, this is what I need to do to cover my ass, and this is what we're going to do, without remotely getting into what's going on with the patient.
Yeah, that particular element of that story speaks for itself as kind of a disaster. It's particularly bad when the patient feels that they're stuck as kind of an object rather than a real human being, which is what we can counter. For people who are interested in learning more about the research we are doing, I will mention the overall study website is csiopioids.org. And there's even a link there you can find if you are considering an interview in the study. And again, as you said at the very beginning of this discussion, Saul, this is a very sensitive subject. For people in distress, we want to really encourage people to seek help. 988 is the National Suicide Lifeline in the United States. You can also find resources on the website for the American Foundation for Suicide Prevention, which is afsp.org.
Thanks so much for this conversation and for the important work that you're doing, looking at this through a lens that focuses on chronic pain and the role of the physician, and unfortunately, and sometimes making things worse, even with the best of intentions.
Yeah, thanks, Saul, for this opportunity, and just look forward to coming back to this subject with findings in the future.
I look forward to it as well.
We hope you've enjoyed this latest episode of On Becoming a Healer. If you have and you haven't already subscribed, please consider doing so now. Also, please rate us on the Apple Podcast app, as it will help others find us. And if you have a few moments, leave a review. In addition, if you'd like to make a comment about this episode, we'd love to hear from you. There are a couple ways to do that. If you're using the Apple Podcast app, then just open the episode website link and enter your comment there. Or you can directly go to the website contextualizingcare.org, select the podcast tab, and then scroll down and click on the episode. There you'll find the same comment box. Finally, you can always reach us at onbecomingahealer@gmail.com.